I'm Chuck Christian. I'm the Vice President of Technology and CTO for Franciscan Health. Franciscan is a 12 or 13 hospital system, depending upon how you count them. We cover a swath of the country in the Midwest, from right south of Indianapolis all the way to Chicago, basically following the I-65 corridor. We have somewhere between 350 to 400 locations, including physician practices, imaging centers, lab draws, urgent cares, and oncology centers. And so it's a pretty good sizable organization. We have about 29,000 team members, both employees and contractors at Franciscan Health. And so we truly are a mission focused. We are a Catholic healthcare system with a big C. We are owned by the Sisters of St. Francis of Perpetual Adoration. That means that there are two sisters in the chapel praying for whatever they deem important, anything we ask them to pray for 24 hours a day, 7 days a week, 365 days a year. That's where
Wow.
the perpetual adoration comes in. So we are a mission-driven organization. I believe in that. And a lot of our hospitals are smaller in places that are underserved. And so we take care of that patient population, and I think we're really good at it. I've known this organization for, I guess, almost 40 years. The CIO previous to Charles, who is our current CIO, was a good friend of mine. I was the CIO of a hospital in southern Indiana for 24 years, and Bill and I ran a similar stack of software. So I watched Bill, learned a lot from him as far as how he ran this very large organization. So I've been here for 6 years, and I joined in April of 2019. So it's been, in dog years, it's like 35 years or more. So we're very busy. I'm very blessed of having an outstanding team that manages this stuff, and I just get to stand in awe of watch everything that we get to accomplish every day.
That's fabulous.
Great.
Thank you, Chuck, for that intro. Ritu, would you like to do a quick one? Then we can jump in with some next steps.
Sure. My name is Ritu M. Oberoi, and I'm the managing partner here at Demo and Big Rio, and also the co-host of the Big Unlock podcast with Rohit. And thank you for being our guest on the podcast today, Chuck. And we are really looking forward to an engaging and insightful conversation. So with that, we can dive right in and get started. Thank you.
Thank you.
Yeah. Hi, Chuck. I'm Rohit Mahajan. I'm the managing partner and CEO at Big Rio and Demo Consulting. And it's really great to have you on the podcast. Like Ritu said, looking forward to an engaging discussion. Would like to start up with the first thought in my mind is that you're a mission driven organization, and you have been a healthcare leader for several years now. What started you, Chuck, on this journey? Tell us a bit of the story on how you got started in healthcare, what attracted you, and what are some of the things that you're passionate about.
It depends on how far back you want to go. I'm an X-ray tech, radiologic technologist, if
Oh,
you're going
wow.
to use the term. The first 14 years of my career was in radiology. I literally stepped out of high school on June the 6th in 1971, and on June the 7th, I stepped into the hospital, and I haven't left since. And
Wow.
so, interesting enough, I did a lot of things in the radiology department and became part of the management team of that department. And I guess if the chief tech had not been just a few years older than me, I'd still be there, because that's the role that I really wanted. But Roy just retired a few years ago, and so I wasn't going to wait that long. And I'm a geek. I'm a nerd. I was a nerd in high school. It wasn't cool to be a nerd in high school back then, but it's cool to be a nerd now. So and so I did a lot of programming classes and stuff back on the old System 3s. I don't know if you remember those or not, where you use punch cards.
Yep. Yep.
And then I learned how to code for Z80 processors. And when we started automating hospitals back in the middle 80s, I got chosen to run the ambulatory implementation of order management after we had already put in patient management. And so I realized that I liked it, and I knew that that was where healthcare was going to go. Radiology has been a high-tech department in the hospitals for a long time. And so I was actually trying to automate the patient record in radiology, but it was just so expensive. I couldn't get any funding for it. So I jumped ship, moved over to the dark side to the vendors for about 5 years, and eventually was asked to move to either a implementation manager's role or to the director of an outsourced IT department in Southern Indiana, which I did. I had 4 daughters at that time, and that was the right thing to do, because it was a great place to raise my girls. And so I've spent 24 years, and as during the time that the role of a healthcare CIO was defined. And when I left that job, I was the vice president and CIO, and moved down to Georgia to a health system down there, was vice president and CI, chief information officer for there. And I came back to Indiana and worked at the Indiana Health Information Exchange, which is now the only exchange in Indiana that I had been involved with since 2005 already. And so I had the pleasure of working there for a little over 4 years, and then I took this role here. So that's kind of my stint in healthcare that has spanned over 50 years.
That's awesome, Chuck. You've been there, you've been
Yeah.
done it and seen it as well. So
And I
now,
got a T-shirt too. So
of course, of course. So I was very curious. Just before the podcast, I remember a few days ago when we were chatting, you were talking about, I think you were either back from the UGM or you were just going to go there.
just going. Yeah.
Just about
Yep.
going there. We all know that it's a week-long affair. People really dive deep in. There are so many things to be covered over there. So we were wondering if you might be able to share some of your experiences or hit upon certain topics, of things that you see coming our way.
Sure. Well, I will tell you, I came home with a great deal of anxiety
Mhm,
because of trying to figure out exactly how we're going to do everything where healthcare is going and where it needs to go.
mhm.
I mean, the nice thing about Epic is they're covering now a gambit. I remember when Epic started, they were only in the ambulatory space, and then only in the large academic medical centers. And they're covering quite a scope of product these days and times. And now that they have grown their applications and they have de-identified shared data, I think it's going to be a really plus. Of course, the 2-letter acronym was everywhere, AI,
Yeah.
and how that's going to be leveraged and how it's going to be used. They did a really nice job of doing some scenarios about how it could be used and how other organizations are using it. We're a little risk averse organization, and we're taking a more moderated approach about there. We're giving our governance in place first. We already have a few things that we have going through the AI mill, and we will have more. And we kind of split it into two pieces: one on the clinical side and the other one on the operational side. And
Mhm.
Epic has both, and I think they're well positioned to kind of do that work. They partnered with Microsoft, and they continue to do so. I mean, they made an announcement they were going to. They're working on their own ambient listening. They have
Yes.
several business partners. They're already working on creating their own product. I assume it's going to be predicated on the Microsoft stack, but they didn't say, so I don't know. The other thing that they made mention of that they're working on their own ERP, and they're starting off around workforce management. And so that,
Wow.
and that makes sense because the workforce is in Epic all the time, and how looking at nursing, staffing, scheduling, shifts, and a whole bunch of other things, and how all that ties together. It makes an interesting leap. It's kind of like years ago. I don't know if you remember when Lawson,
Yeah.
before they were purchased by Infor, they decided they were going to create a patient accounting platform. I was in there at a Chime Fall forum, and I was in their focus group. And when they mentioned that, all of us, there were a bunch of CIOs in a room, was, why would you want to do that? You need to get your ERP right first before you start trying to think of something else. And so, but I think that, the way that Epic is approaching it, it makes sense of how they're tying it into the other things that they're doing. But it was really great. I was only there for about 4 days,
I see.
and spent most of the time listening to quite a few presentations. Judy did a great job of with the big screen about what's next, what's coming, and then the rest of her team did a great job of providing the. Did you know this is what you can do already? And then here's
Yeah.
what's coming. And so, and they do a fairly good job of setting expectation around timelines. And when they do that, they put it out there. We're like everybody else. They're doing quarter releases. We do 2 a year, so we do 2 in the early in the year, 2 and later in the year. So we're current as far as they're concerned, but we're behind. We don't have the wherewithal to, and when they drop it out there, for us to immediately adopt it. So we have to plan accordingly for that.
Right.
Yeah. So Chuck, when I was reading about the UGM, it was interesting because they said that their unique proposition with AI is the de-identified patient records that they have, the Epic Cosmos, which is more than
Yep.
15 billion patient records. And
Right.
they said for the first time, it can actually move towards healthcare rather than sick care, because the doctors can, predict trends. And then I think they've released these two new things called Emmy and Penny, which will help, doctors
Yep.
go ahead and see the trajectory of what the patient's is going to happen. So what I was very curious to know what your thoughts were about that, because you've been in this industry for such a long time. Do you really think that USP that they have with this huge bank of patient records is really going to set them on a differentiating path, with respect to all the other AI startups which are trying to do the same thing?
Well, I mean, I think that having the data is huge, to tell you the
Exactly.
truth. And the
Yeah.
fact is, it reminded me a lot of, if you remember, years ago they had a thing called Patients Like Me, where people that have these unique and rare diseases, they can find other people that have those, and so they can compare notes
Yeah.
and do treatment stuff. And so that was one of the things. Having worked at the Indiana Health Information Exchange and understanding, they've got about 30 years of data that's not all of it's discrete, but the grand majority of it is. And one of the questions I ask, the CEO is a friend of mine, and there's a lot of researchers that use parts of the de-identified data to do research on, is that creating an AI model that you just letting it learn. And there's all kinds of really interesting things you can make a determination if once you have the data. And so I think that that's going to be a game changer. But really and truly, Epic is trying to outdo themselves, because with the current market of EHR vendors, there's not many left standing because of a variety of reasons. And there's 3 or 4, and I'm not sure that. And I think that there are others are creating a very similar repositories, but I'm not sure if they have the long-term vision or the wherewithal to get it done. So it's I'm knowing some of the talent that Judy's been able to pull together, and others. I think it's going to be something that's going to be very, very interesting to see what comes down the pike.
Okay, thank you.
Yeah, Chuck, you mentioned that you are taking a little conservative approach to AI adoption, and you are setting your governance, possibly in place before taking any major steps in that direction. So, how do you think about, innovation or, you know, solving typical problem solving, let's say reducing the cognitive load across the organization? So how do you, marry or balance this conservative approach vis-a-vis the fast-paced changes that are happening in the marketplace?
Well, I mean, I think that we have to make be very clear about what problem we're trying to solve. There are
Yeah.
so many solutions that are just being thrown at us to say, hey, we can do this, we can do that, but it's not really a problem that we have. And so trying to pick and choose, which targets that we shoot at. And one of the things, I'm married to a critical care nurse, and so I'm very, very careful about getting in the way of the nursing staff. She's retired. She doesn't practice anymore. But the thing about it is that for me, technology needs to be invisible. If it gets in the way of people being able to do their job, then it's a problem. I mean, and if you think about it for a minute, and I'll give you Chuck's opinion, is that we don't really have electronic medical record systems, okay, as far as documenting the care of the patient. What we have is we have electronic systems that capture information that's required for billing.
Yeah.
And that's part of the problem as far as I'm concerned, is because we have all the things that are required that they have to document, and all the things that the physicians have to do to dot all the I's and cross all the T's to make sure we get the appropriate words stated or written down so that can be translated into billing codes. So it can be translated into ICD-10 codes, to HCPCS codes, and all the other codes, that it truly gets in the way of people taking care of patients and getting us to understand it. But on the other hand, once we get that discrete data, we can use things like AI and other things to help determine what a better course of treatment may be. And you're never going to hear this guy say that we need to depend solely upon AI. It's got to be moderated and reviewed by somebody that has a clinical mind, that's been clinically trained. I've been well trained by physicians and shown that I've been wrong on more occasions than you can imagine. But I think working together to provide that level of data aggregation, one of the things that I learned a long time ago when trying to implement some of the first physician order entry and the first clinical documentation systems out there, is that the physicians basically said, don't tell me what I already know. Tell me what I don't know, but better yet, tell me what I need to know about the patient that's in front of me right at this moment in time. Things I do not know, and I think that's where the data aggregation of health information exchanges come in, is because patients don't get care in one location. They don't get care in one physician, and I'm living proof of that. I have two health systems actually three, that I get care at, because that's where my specialists are. I have at least three physicians that are one at each one of those health systems. So I'm getting care in different locations. So when I go see my primary care physician, he wants to know what my orthopedist who just put me back together again because I tore something, or my cardiologist, what their course of treatment has been for me, because he's trying to take care of my diabetes and a few other things. And so having access to the information and having access to the most recent labs or most recent imaging studies is extremely important. And we talked a little about interoperability, and that's where all that comes in to play. And it is working, because most of the hospitals in Indianapolis are on Epic, and you can get the data from other Epic systems fairly easily. Other non-Epics, there are mechanisms to do that. And when I go see my cardiologist who is using a different system, and he already knows what my medications are that were recently changed by my primary care doc and my cardiologist. That's really a positive, because then I don't have to pull up the list and kind of dictate that out. And when they know what my last labs and stuff were, that's a positive as well, because we're not having to go hunt for those. That information is readily available. And I think that's the key, is providing that information on a basis that is important to the treatment at that time. One of the things I had the privilege of sitting through at a presentation, I guess it was probably maybe 8 or 9 years ago at Regenstrief Institute, is they were basically showing a demo, and this was kind of it truly was a demo of what the patient encounter in a physician practice could be. Very Star Trek-like, where the computer or AI is actually interacting with the physician and the patient appropriately during that patient encounter. And in the background, it was listening to and capturing information about the encounter. When the physician would say, we need to order a CT scan of your lower abdomen, it was in the background already getting that schedule teed up. So when the patient was ready to leave, everything was scheduled. And it was looking in the background for any recent lab results that might have been done at another location, and providing that information either on the screen or verbally to the physician, and reminding the physician that the patient may be due, if they're diabetic, due for an eye exam, a foot check, and those type of things. And so I think that it's having access to the information so we can inform, not determine, but inform the physicians, because at the end of the day, the physicians are accountable for the outcome of those encounters. And so I think they have to be in control of what occurs rather than the AI.
Yeah.
We're
So Chuck,
not ready for Skynet yet. So
yeah, I
Yeah.
think you just described a multi-agent system where the agents are off doing,
Yep.
things and then bringing it all back and for the physician to review. So with that being said, we all know that agentic is, one of the top trends that everyone's talking about these days. So what are your thoughts on like voice agents, and where is Franciscan, with that? And have you had exposure, or are you trying voice agents for the hospital? What do you
Yeah,
think?
we've got a trial. We've got over 200 physicians that are working on those. Is it going to be the end all end all? I don't know. The physicians seem to like it. It assists them. It helps with their pajama time, and so I listen to other conversations with other health systems that have were early adopters, and I have to go back in time where we were looking at, when I was in Southern Indiana. We were picking a system to automate all of our physician practices, and we went over to a group of family practice doctors. There were, I think, 14 of them. And there was a husband and wife who actually started the practice. A lot of their practice was OB and family medicine. And their use of the computer, they mostly was still on paper, even though, and then they had other physicians that basically, I think they slept with their laptops, to tell you the
Wow.
truth. But so and so the interesting thing was, depending on how well that physician had adopted the use of the computer system and molded it to the way that they practice medicine, they got to take advantage of that. And I think that's going to be the same thing with AI and the agents and that kind of stuff. If they allow it to help and they figure out how to incorporate that into how they think and how they practice, and the systems are getting pliable enough now that that's pretty easy to do. When I was in Georgia, I had a task. We needed to automate a lot of OB practices on the same platform. And I had one OB that had been practicing there for almost 30 years. He already had a solution in place that he had customized for his practice, and he liked it. And he told me that I would tear it out of his cold, dead fingers. And I said, so it's a challenge. And so we worked with him, and the new system was even more flexible and pliable than his previous one. And he became a champion because he was willing to take the time and understand how that he was able to take advantage of the technology in order to help him practice. And I think that's the key. Is if you're going to be resistant to it, that's fine. I mean, that's perfectly okay. And I also think that when people who write software think that all physicians think the same way, they're absolutely wrong. It depends on where they were trained.
Yeah.
I learned that when trying to implement emergency room electronic medical records. I learned very quickly that the people that wrote the software, the physicians that were part of the consulting group that helped them write the software, was trained at a very much different manner of critical thinking than our physicians were, and so we had to relearn and figure out ways because once they have been trained that way, it's really, really hard to change those habits and the way that they gather information and put it all together and maintain it.
Thank you. Great answer.
Yeah. And Chuck, would like to ask you your thoughts about the innovation process. How do you
Sure.
approach it, and like what are some of the things that you do to foster, innovation?
Well, one of the things we did, we stood up a tech innovation lab, and it basically was it was a selfish thing that we did because people were just bringing in technology into the organization. We had all the enterprise architects report to me, and we worked together to create the environment. We know what will work in the environment and what won't work. We try to standardize as much as we can. And so I created the Tech Innovation Lab in order to bring these innovations into the lab, try them there,
Yeah.
because it's a walled garden, if you will. It's not
Yeah.
connected to the rest of the network. It's all by itself. It's firewalled off, and it has its own connections to the internet and those type of things. And so, if we blow something up, it's
Yeah.
only going to blow up in the lab. And so that's the reason we did it that way. But what we are able to do is bring it in and fail fast,
Yeah.
figure out what's going to work, what's not going to work. And we've done that on several occasions. Virtual nursing is one of the things we've worked on quite a bit. There were all kinds of really interesting opportunities that were brought to us, and we started putting those into the lab. We had one enterprising facility and went ahead and put it in a patient population and started trying to use it, and really found out that that's not the way you do it. You don't do that kind of research, if you will, in a live patient environment because it creates frustration with the staff, with your patients, and it actually leaves a bitter taste in leadership's mouth in order to, when you start talking about, no, we've already tried, that doesn't work. Well, you tried what doesn't work. So let me show you what will work. And so I think that you need to have an opportunity to rapidly figure out what will work, working with your kind of your standard practices. One of the reasons that that experiment didn't work is because the people who built the carts didn't understand our environment. They had put a wireless access point into the mobile cart that was incompatible with our network. Once we got a hold of the cart, we figured it out pretty quickly, and so we re-engineered it, and it works fine now. But we're not using that cart because it was over-engineered and very expensive, which was great for the people that were building them, but it was something that we're trying to use something that's standard that can be supported not by my team, but by using standard components and that kind of stuff that that can be just replaced very quickly. So the idea is to come up with a lot of different ideas and figure out how to use them appropriately and not get in the way. One of the things that we originally did, and you have to think about the aesthetics of the equipment that you're bringing in. one of the first things is, was a cart. They had a big 5-wheel, it was, kind of a star topology on the wheels and stuff. Some of our patient rooms, it was in the way. And nursing very quickly said, that's not going to work. So we had to come up with a way. So now what we're doing is we have found an iPad, a holder, if you will, that when not in use, it hangs on the patient's bed rail. Out of the way. It's very easy. And they said, well, what, it plugs into the wall, doesn't, is it a trip hazard? No, because it's got magnetic connectors. If it gets snagged, it just comes apart. So it's not a trip hazard. So, I mean, so you have to take in consideration not only the technology that you're presenting, but how it fits into the patient's rooms. And one of the things, the original idea of the innovation lab was we would come up with, we would review the technology, make sure we understand how it all fits together, how it would need to be installed. Then we would install it in our sim labs. We have two, one north, one south. And then we would put it in the sim labs and get the simulation teams to actually put it in a physician office, put it in a patient room, see how it was going to fit with the environment and if it was going to work or not. And so that's kind of our next steps on doing stuff with the virtual. But we know that. And the other thing we do is have a lot of conversation with other organizations that have already done it and have it fully rolled out and deployed. And we learn from their experiences. I was going to say mistakes, but a mistake is only a mistake if you don't learn from it. And if you do learn from it, then it's experience. And so we learn from their experience and leverage that experience so we don't have to repeat those same things and so we can move quicker.
That's awesome. That's awesome. Ritu, would you like to, as we are approaching the end of the podcast, I would like to ask Ritu if she would touch upon the mentorship program that Ritu,
Sure.
you
Yes,
think with
I would really like to hear more about that, Chuck, because that's something, really unique, and I think it would be really interesting for our listeners as well.
But I just make sure we're talking about the virtual mentoring that we did, or okay.
Yes.
And this is, after COVID, we were bringing on quite a lot of new nurse graduates. And when you bring somebody into that, they need to have a more seasoned, experienced nurse for a procedure they may have never done before. Well, and so that means that they have to wait and bring that nurse to them. And so what we came up with, we didn't do it. We had a couple of nursing staff and the mentorship program that they have that came up with a way of using technology to do really on-screen a virtual visit to the student or the new nurse, not a student nurse. She a graduate nurse. And she would walk them through the procedure and be there for them while they were doing the procedure. Or if they just had a question, they could step out in the hall and ask the question and go back in again. So it was speed to delivery of care, which is more than anything else. And it also gave the seasoned nurses an opportunity to just step away from what they were doing for a second, rather than having to go to and travel to another location. But if they need to do that, then they still do that. That's not the only way we do mentoring. So it got great feedback from both the new nurses and our more mature nursing staff. That was very beneficial, and we rolled that out through the enterprise. Now, I haven't checked in on it recently, so I don't know if it's continues. I assume it has. I only hear when things break, and so if it's not broken, I'm not going to go try to fix it. But I assume that the technology is still working, and it's having paying dividends and benefit as well.
Cool.
Great. Thank you so much.
You're welcome.
So, Chuck, as we come to the end of the podcast, any other closing remarks or thoughts that you would like to share before we finish?
Well, I mean, I've been in healthcare a long time. Healthcare is a target-rich environment for creativity and innovation.
Yeah.
However, We're still taking care of patients the same way we did, and it's about the human touch, and it's about caring for those bodies. One of the things when I first started in radiology eons ago, I was taken back a little bit about people weren't people; they were exams. Go do this gallbladder in this room. Go do this hip nailing in this OR room. And I was reminded that they're people. Those could be my family. They could be my children. And so, and that's the reason I'm pretty passionate about making sure the technology works and doesn't get in the way. Have we gotten to that pinnacle? No, not yet. Is it better? Yeah, I think it is. But we're still trying to figure it out every day. And as long as we have great people that are passionate about providing outstanding care to our patient population, and we understand that the ability to do that, where it comes from, is very, very important to us. I mean, and one of the things that, and sometimes when new vendors come in, we're a Catholic healthcare system, and our rule is we start most meetings with prayer. Actually, I start most meetings with prayer, and we are called to love one another as God loves us. And so we will need to be reminded of that every day, that we need to take care of our patient population. And that's the reason I keep doing what I'm doing.
Awesome.
Thank you so much, Chuck.
Yeah,
You're very welcome.
Yeah, really appreciate it.
Okay, thanks for the opportunity to share.